It is actually a shirt. It is not even a dress.
Yeah, thanks for enlightening me with your knowledge on dresses. Okay, are we live on
Yes,
YouTube?
madam, we are live.
Yeah, good evening, everyone. I think we are meeting this week, second time, with a very interesting topic of pre-implantation genetic testing for aneuploidy, which is also called as PGTA. As the vitrification process is getting more and more standardized and with excellent results. Also, the trend now is towards reducing the multiple births and transferring that one euploid embryo, which can result into a live birth for that couple. So the detection of aneuploidy, which is very challenging, has now taken a forefront in IVF clinics, because we are dealing with more and more older couples, older females who come for IVF. So to give I think overview of what exactly PGTA is and what is its role in fertility practice, we have Dr. Jay, who does a lot of this work in his clinic, and I have personally seen him counsel a couple of my patients and patients in Karnataka who have taken this services from his clinic. So over to you, sir. I think you can start.
Yeah. So first of all, I want to tell that PGTA is a very overhyped procedure. Okay. It is a very, very simple thing. Okay. There is no need to hype anything about PGTA. It's okay. It's a very, very simple thing. It is not a rocket science service which you need. If you do PGTA in your laboratory, you are, fetching water from the Mars. There is no such thing. It's a very, very standardized procedure. That is the first thing. Second, we ourselves have been doing PGTA since quite some time, and many, many people, I guess, have been doing PGTA since quite some time. Okay. So, what is it that we really need to keep in mind as far as PGTA is concerned? See, whenever you are having whenever you are having this thought of doing a genetic testing, now the indications are no longer that the couple should have had history of multiple abortions, couple should have had history of a genetic disease. Let's say in Bombay it is very common for couples who are having thalassemia trait to get married to each other. Thalassemia minors getting married, and then they want to avoid a thalassemia major child, right? So these type of indications are the traditional indications for doing PGTA. It is important, very, very important in my opinion, to understand that as the age of the female partner keeps on increasing, the probability that you will get a euploid embryo in your set of stimulation keeps on decreasing. Okay, so if in case you were to do, let's say somebody at age 35, she will give one euploid embryo for every 5 to 6 eggs or every 5 to 7 eggs which you obtain. A lady at age 38 will require around 14 15 eggs to give you one euploid embryo. A lady at age 42 43 will require maybe 25 30 eggs to give you one euploid embryo. And this is very, very important to understand. Okay, when you understand this, you will understand that, as Shilpa madam mentioned, as more and more elderly couples come to seek treatment for fertility, obviously you want them to have a chromosomally normal embryo or a euploid embryo which is inserted inside. And this euploid embryo which is inserted inside can only be tested by doing genetic testing for aneuploidies for these embryos. Okay, which is where the role of PGTA comes into practice. Okay. Now, when is PGTA ideally to be done? Okay, please understand, once upon a time, we used to do PGTA when we started at day 3 embryos. Okay, and that was the time when day 3 embryos culture, day 3 embryos freezing was very standardized. But the big problem is embryos which are at day 3. Let's say you have 4 embryos which are excellent, top quality embryos at day 3. There is no guarantee that out of these 4 day 3 embryos, all 4 will form blastocyst embryos. That is the first thing, right? Second, when we were doing biopsy at day 3 embryos, okay, one, apart from this failure which we encounter, there is a big chance that the embryo will lose around 10 to 20, 15% of its genetic material. It is an 8-cell embryo. You are taking out 1 or 2 cells for sending in for PGTA, and the embryo loses its genetic material. though this embryo will recover itself, but there was a real risk of losing that. Okay, as a result of which, as more and more people shift to doing day 5 embryos, the good thing about day 5 embryos is that you have around 100, 120, 140 cells, and out of that, if you have laser, you will end up with 6 cells as biopsy. Once you take these 4 to 6 cells, I'll just draw it and show it to you, just in case somebody is interested. Um, I don't know how many of you know, but once upon a time, I was a traveling embryologist doing PGTAs at multiple locations. So I have a wonderful video of how trophectoderm biopsy was done. Okay, that is my video, how I had done a trophectoderm biopsy. I think it is 5, 6 years old. And I think it's a wonderful video because I think that has been a training video for more than 200, 300 embryologists who are now doing PGTAs. Okay, but I'll just share the screen to give some basic points on that. Yeah, you can see that, right, Shilpa madam?
Yeah.
Whiteboard, right? So, okay. So it is important here that we understand. Oh, I'm unable to write on this. Okay, wait. Sorry, I just shared the whiteboard by mistake. We're supposed to share screen. Yeah, correct. So when I just share the screen with everyone, I just want everyone to know this thing. See, how do you do this entire thing for the embryo? Okay, let's say this is the embryo, blastocyst embryo. You have multiple trophectoderm cells. You have an inner cell mass, correct?
Yeah.
Shilpa madam, you can see all this, right?
Yes, yes.
Okay. And surrounding this, there is a thin zona pellucida. So when you have this thin zona pellucida, which is surrounding this embryo, okay, you are supposed to position the embryo along the border across the inner cell mass. So this is your inner cell mass. This is the trophectoderm cells. Okay. And you are supposed to break with the laser onto this zona. When you break the laser with the zona, you have a pipette, and through this pipette, you will be absorbing approximately 4 to 6 cells. So approximately 4 to 6 cells are absorbed like this. Okay. And then you apply another laser basically in order to cut that. Okay. So you just cut that much with the laser. The embryo will then undergo shrinking. This embryo will then shrink. Once this embryo shrink, you culture it for around 30 minutes and then you do freezing. Okay, this is the standard procedure. The recovery of this embryo is excellent. So once you thaw this embryo, it is going to have an excellent recovery. Don't thaw this embryo and then do laser assisted hatching. Remember, you have already lasered it. So just thaw this embryo and transfer. These 4 to 6 cells which you then take out. Okay, these 4 to 6 cells which are then taken out are then transported inside a shipper where you have these 4 to 6 cells in a solution. Okay, so what they are going to do, they are first going to run a QA/QC. They are going to run a quantitative assessment test, quality control test in order to see if these cells are viable. After these cells are viable, these 4 to 6 cells are going to be subjected to a process of amplification. Okay, this amplification has to be done mandatorily. And once this amplification is done, then they are subjected to a platform called next generation sequencing. Okay, this next generation sequencing helps you in identification of most of the aneuploidies which you are trying to look out for, and as a result of which the report will take around 14 days to come. Should you be wanting to look at monogenic disorders, okay, which are storage disorders, hematological disorders or something like that, after you do a PGTA, you also do couple karyotype and you switch the patient to something called as PGT-M, where it looks into a single gene disorder and it rules out these embryos who are having these single gene types of disorders, and then you can go ahead and place these embryos. Okay, I think what is important to understand here for everyone is very, very important thing. These embryos which you are wanting to biopsy have to be day 5 embryos. Okay, approximately 108 to 116 hour embryos. The reason why I'm saying this is at 108 to 116 hours blastocyst. Okay, the chance of having a euploid blastocyst is the maximum. You can also form day 6 blastocyst, but remember a day 6 blastocyst has a higher potential of being aneuploid. Okay. And finally, once you have this PGTA, PGTM, whatever report you have, I just want to state very, very clearly, because for clinicians, after understanding all these things, what is important to understand is this. Okay, now after you have done PGTA, you can have only three possibilities. Okay, the embryo can either be aneuploid, the embryo can be mosaic, or the embryo can be euploid. Okay, there is no other possibility. Obviously, in mosaic, you have two options. You have low mosaic, you have high mosaic. Okay. So what is a euploid embryo? First, let me just clear that. We think euploid embryo is an embryo which is 100% normal. That is wrong. An embryo having less than 30% abnormalities through its gene sequence, okay, is labeled to be a euploid embryo. All right. This is excluding all the critical defects. Okay. An embryo which is mosaic is somebody who has between 30 to 70% abnormalities. Okay. And an embryo which is aneuploid has more than 70%. So now it is very, very important for people to understand that an aneuploid embryo is usually labeled as non-transferable. That means if you transfer this embryo, most probably the patient will either end up as an abortion or it will have a negative outcome. Question with euploid embryos is again very simple. It is obviously a transferable embryo, and this transferable embryo has a higher implantation potential. But it does not mean that this implantation potential is 100%, but a single euploid embryo usually has an implantation potential of 50%. Okay, that is a good enough way to counsel the patient. The debate comes between low mosaic and high mosaic. Okay, so just remember, when you do an embryo biopsy, I'm just sharing a shortfall of this procedure. When you do an embryo biopsy, this embryo biopsy is an embryo which is, let's say, embryo 108. This was the karyotype of this embryo. It can also happen that God has gifted these embryos with a property of something called as autocorrection. Okay, so even if an embryo is labeled to be a high mosaic embryo, it can undergo autocorrection on its own and it can become a low mosaic. And when you do this embryo transfer, it can give rise to a positive outcome, which is a healthy pregnancy. This is something which you have to keep in mind very, very, very strongly. This is one of the pitfalls of doing a PGTA. Okay, this is one of the pitfalls. All right. The second pitfall about PGTA is because you are taking a biopsy. Okay, you require expertise. Okay, now let's assume, irrespective of what people say, this expertise is not standardly available across the country. So when this expertise is not available standardly across the country, you require a lot of training. The person who is doing PGTA requires a lot of training. In order to eliminate this training, companies have come up with something called as non-invasive PGTA. Okay, and what is a non-invasive PGTA? Non-invasive PGTA means, okay, non-invasive genetic testing. Basically, what it means is your embryo is being cultured in a culture droplet. Inside this culture droplet, you have your embryo here. You have this embryo here. Let's say the embryo is being grown inside this culture droplet. So instead of doing anything to the embryo, you are going to use a pipette and aspirate this fluid. There is all this fluid, no culture medium which is surrounding. So it is believed that embryo releases some of its DNA inside this, and when you absorb this fluid, approximately 8 to 10 microliter of this fluid, it is going to give you approximately 50 to 80% of equivalence to doing PGTA. That is in the current perspective. Obviously, we hope that as time goes by, non-invasive PGTA is something which becomes more and more and more better, because when non-invasive PGTA becomes better, it is very good for the patient, because you can actually do this on a much wider scale and it will cut down the cost of doing this procedure. The expertise which is involved in this procedure will completely go away and it will become better. But I think we are around 5 to 7 years to go. Big problem is that for doing a non-invasive PGTA, you require standardization of drugs and you require standardization of culture media. Also, you require standardization of incubators and standardization of the IVF QA/QC. Now, we all know in a country like India, It is absolutely impossible to standardize all these types of things. So till all that really happens in our country, we are looking at, by the time let's just imagine I would have finished practice, and I would have finished practice by doing maximum number of embryo biopsies, world record, something like that. But till that time, I don't foresee that something like this would happen very frequently in the country. Lot of times people are worried about the cost of PGTA. So I would just give a standard estimate. On an average per embryo testing for NGS is going to cost you around 12 to 13,000 rupees. Maybe in the next 2 to 3 years, it will come down to 5 to 6,000 rupees, going by the number of NGS kits which are available, because it is a kit dependent game, not a machine dependent game. Okay. And then comes the expertise of doing the biopsy. So it depends really who is doing the biopsy and how it is being done. One more thing, if the biopsy is done nicely, this embryo will survive, and there is no negative effect on the outcome of the fetus. Okay. And one more thing which you should keep in mind very importantly is that even if you put a euploid embryo inside the uterus, it can still have abortion. Even if you put a euploid embryo inside the uterus, it can still be a negative result. Even if you put a euploid embryo inside the uterus, there can be cervical incompetence and the pregnancy can still abort. So in the long-term perspective, again, as the age of the female partner increases, the beneficial outcome of PGTA and euploid embryo keeps on decreasing. Just keep that in mind. Okay. And with that, I conclude. Probably I can answer one or two questions on this basic lecture, and then the rest of the questions on WhatsApp.
Basica. This was the advanced lecture, I thought. Okay. Anyway, so we are talking about whether to transfer one PGTA, that is the biopsied blastocyst, or whether we transfer just two blastocyst without doing the biopsy. So many trials, like the BEST trial and all, have shown that the results are almost the same without any added benefits. And also, so yeah, you answer this. I mean, what is your thought on this? I mean, would you recommend doing a biopsy in all cases, or would you selectively offer biopsies?
We only offer biopsies to patients who have a past history of multiple abortions, more than 2, 3 IVF cycles failed, or having some genetic cause. Apart from this, like how it is done in some countries, for example, in United States, doing a PGTA is mandatory, right? Every patient, 100% of the patients who do IVF will have a PGTA done. Okay. Now, that is more in order to create something called as a gene bank, which they want to create as a country. That has got nothing to do with the IVF success rates. Okay. For example, I'll give you an example of another country. In China, it's one of the best countries in the world as far as annotations are concerned. Okay. So they will annotate the embryos brilliantly well. China does a lot of time lapse. Because they do a lot of time lapse, they have their own annotated configurations that the embryo which matches all these criteria is most likely to be a euploid embryo. So they don't apply PGTA very frequently in their country as long as they feel it is a euploid embryo. Understanding? And even their data shows that doing PGTA routinely is not indicated at all. At all. Okay. So we don't do it. We don't do it routinely, and nor do I think it will help. There are so many people in our country who are opting for embryo donations and all these things. When they do an embryo donation, they don't opt for PGTA because it is believed that these are embryos of young couples, and young couples has a higher chance of euploidy, as a result of which couples who opt for embryo donation or embryo adoption, even these couples have an excellent outcome in their primary or their secondary embryo transfers, irrespective of their age, right? And that is because of the higher euploidy in younger couples.
Okay, so you told about the annotations and the morphology. So we have a spectrum, like say we grade the embryos based on the morphology. We have time lapse and we have PGT.
Yeah.
So, so majority of the basic IVF clinics would generally go by morphology because we don't have the time lapse machine, or we don't have the expertise to do the PGTA. So with this morphology, so how many, what is your recommendation? Like when do we shift from this morphology to either PGTA or time lapse? Is it like the clientele that we see? Is it that we do only self cycles? Is it at that time that we find these to be more and more useful for either patient satisfaction or for offering them the latest technology what is available?
No. Honestly, see, a good embryologist is better or equivalent to a machine. That much I can tell you. So if you don't have time lapse or PGTA, all you need to have is a good embryologist. Okay. Let's assume you have a good embryologist and you have time lapse. Please remember that in Indian situations, these days you have these lot of companies which are available with AI based tools which help you in selection of these embryos without time lapse. Okay, they have basically copied data from time lapse and they have gone reverse calculations. Okay, and they are applying that reverse calculations to the embryos which are formed. But these are not calculations done on Indian embryos. Okay, so one must really keep that in mind, that when something is not calculated on Indian embryos, you need to be little careful. Otherwise, time lapse is something which is good only for patient satisfaction, nothing else. Okay, and we've already discussed PGTA.
Yeah. So coming to like, I mean, late 30s and early 40s women who are now becoming more and more common in our IVF practice. So is there a cutoff in the age, like say after the age of 42, if they come for self cycle, do you, I mean, offer them the PGTA even before you start stimulation? Or because anyway, they will not form many embryos, right? They will have low AMH. So you just tell them like if it is morphologically okay, I just transfer whatever the blastocyst I get. So how do you go about it and like, pushing PGTA or not pushing PGTA?
You must give them the option in today's time and age. Okay, just give them the option. Don't really pester them to do anything. And counsel that you have given the option, they decided to do it. Counsel that you gave the option, they decided to not do it. Simple. But it is better that if age is more than 37, 38, and especially if they've had a previous IVF cycle with own eggs which has failed, okay, then it is better to document that you have given the option of PGTA and the couple has decided to not do it or to do it, whatever.
So to do the PGTA, I mean, is there any set number of blastocysts you would like to have so that
Four is ideal.
oh, yeah.
Four is ideal, but you can do it maybe on one and two also.
Okay, and the NGS kits that you told, so is it more cost effective if we do it at one go, like if we have 5 embryos or
It is cost effective if you are daily running it on more than 200-300 embryos, ideally. So, I mean, it's expensive. Otherwise, the company which is going to order, see, that is the reason why all these companies which are offering embryo biopsies or PGTAs, they have a centralized system where the cells which are collected are shipped,
Mm.
correct? So that they can accumulate cells from across the country and run it daily on a particular platform because it needs to be amplified, and
Mm.
amplification and culture takes some time, and then you can pass it through the NGS. Okay, so you require a big set of embryos for you to do this. If you
Mm.
are doing it on, let's say, if I say that daily I can do it on, let's say, 10 embryos, for example, then the machine will be not cost effective. It will be expensive.
Yeah, yeah. I think it was excellent. So thank you very much for all the information that you have given. So the rest of the questions we'll take in the group, but I think this was one of the most simplest and most, uh, I think, giving us a lot of practical aspects of PGTA. Thank you. Thank